All right, guys, good evening. Good evening. Right, so welcome back to our BLS series. We took a short, brief break. That was unanticipated, लेकिन कुछ काम था. There's a little bit of, काफी चीजें ऊपर नीचे थी, तो I had to sort that out also. And we've been running the series for almost like 47, 48 episodes. अगर आप देखोगे तो we've been going almost every single week. So it required a little bit of break from my end so that I can regroup myself, थोड़ा सा energy वापस regroup करके, and we're back with banger again. So today I start GIT, which is the much awaited and the anticipated series in the entire BLS. I know GIT से सबको प्यार है, GIT सबको अच्छा भी लगता है, GIT सबको समझ में भी आता है. But as I tell you, boy, GIT is a Pandora's box. इतनी सारी चीजें होती हैं, there are different things to it. Anatomically you need to be sound, physiologically you need to be sound, diagnosis has to be spot on, imaging you need to understand, making decision when not to operate is more important when to operate. ठीक है, एक अच्छा सर्जन वही होता है who knows when not to operate, not the one who actually knows when to operate. क्योंकि ऑपरेशन करना जो है that everybody knows it, there's a clear cut guidelines. वही जो ग्रे एरिया में वो डिसाइड कर पाए कि भाई इस केस को कंजर्वेटिवली मैनेज किया जा सकता है. दिस रिक्वायर्स सर्जरी एंड दैट्स द स्किल दैट यू नीड टू हैव, राइट? हाय, गुड इवनिंग मुंशी. आई थिंक वी आर बैक ऑन. आई थिंक चैट बॉक्स इज अ लिटिल बिट डाउन. लेट मी एक्सेस इट डाउन. Hi Soumyadeep, good evening, good evening, good evening. So all of you, I think we are ready. Let's start our discussion without wasting any further time. So आज हम बात करेंगे esophagus की, and esophagus will start with the surgical anatomy as we always do. So we'll start with the surgical anatomy of the esophagus. We'll talk with the surgical anatomy of the esophagus. Now, many things which we are going to discuss here is going to be absolutely relevant as we go down. Every single point that I'm going to discuss here, in the anatomy, we will start implying it in your disorders, in the diseases, in the surgical management. So this particular lecture is going to be very, very, very important. Hi, good evening, Roshan. Raghavendra, complete the series by December. I will complete the series by December. Don't worry about it. Hi, Osama. Good to see you back. Good evening, guys. Good evening. Chalo. So when you talk about the surgical anatomy of the esophagus, first of all, when you look at the entire component of the esophagus is one, I would say, the part of the GIT which goes through three different environments, right? So when you look at the esophagus, it actually goes through three different environments. It goes through the oral cavity, that is, it is communicating with the oral cavity. From there, it goes into thorax, and from the thorax, it goes into the abdomen. So esophagus is such tricky component that it starts or communicates with the oral cavity, goes into the thorax and then to the abdomen. So it is going to go through all three different environments, and imagine the amount of variation it is going to adhere to. Now, just to start with the entire component, when you talk about the length of the esophagus, remember it is going to be approximately 25 centimeters. It is a muscular tube. Now, when you talk about this 25 centimeters, just to keep the things in rolling component, what are the other structures which are approximately 25, right? One is going to be duodenum. Another one is going to be the ureter. Another one is going to be your descending colon. And the last one is your esophagus, right? So these are the other structures which are also going to be approximately 25 centimeters, right? Somebody's asking, sir, will you complete the thorax later? Guys, on a popular demand in the group also and from on the backhand team, lot of you have requested for GIT to be started and finished, because thorax is a small part of our general surgery. GIT is quite vast and everybody wanted us to start with GIT. So we heard you and we decided, why not? Let's give GIT, no problem at all. So thorax will come back and do it later, but as we started GIT, we will continue to do so. Right now, these are the structures which are going to be 25 centimeters. A small mnemonic to remember: what we call each other is dude, right? So these are the structures which are also going to be approximately 25 centimeters. That is your duodenum, your ureter, your descending colon, and the esophagus. Remember it as dude, nothing spectacular about it. So when you look at the esophagus in general, so esophagus is something which is going to start from the cricopharyngeal junction. So let's say this is the cricopharynx, and from here you see the muscular tube is going to originate, and this muscular tube that is originating is going to be our esophagus. It is going to traverse through the neck. As it traverses through the neck, it is now going to go into the abdomen, piercing the diaphragm and continuing with the stomach, right? So this is the whole journey of the esophagus, starting from the cricopharynx all the way to the gastroesophageal junction. So if I say this is the cricopharyngeal junction, this happens to be your cricopharyngeal junction, and it goes all the way to this point, and this is going to be your gastroesophageal junction. This is what we call it as the gastroesophageal. This is what we call it as the gastroesophageal junction, right? So from this point, that is from the cricopharynx all the way, from the cricopharynx all the way to the gastroesophageal junction, this is going to be 25 centimeters in length. This is going to be 25 centimeters in length. Now, if they want to make it a little bit more tricky, they say, what is the beginning point? It starts from the C6 vertebra. It ends with the T11 vertebra, right? So where do you see the cricopharynx? It is corresponding to the C6 vertebra. And where do you think the gastroesophageal junction is going to correspond to? It is going to correspond to T11 in general, right? Now, when you look closely with respect to esophagus, you will see the epithelial lining is slightly trickier. So when I say the epithelial lining is slightly trickier, what do you mean by this? You will see that the entire esophagus, which is present here, you'll see the entire esophagus is lined by these flattened out cells, and this is what we call it as the squamous epithelial cell. This is what we call it as the squamous epithelial cell. But when you go down to the gastroesophageal junction, the last 2 centimeters of the esophagus, it is lined by columnar epithelium, and from here the entire GIT will be lined by the columnar epithelium. So when you look at the epithelial component of the esophagus, you will notice that majority of the esophagus is lined by the squamous epithelial cells. It is lined by your squamous epithelial cells. But the last 2 centimeters, as we have depicted here, this is the last 2 centimeters of the esophagus. The last 2 centimeters of the esophagus is lined by the columnar epithelium. It is lined by the columnar epithelium, and you can see there is a transition between the squamous to that of the columnar epithelium. Now you take the same component and now we replicate it here. What do we see? You see the entire esophagus. Let's say this happens to be, just for the sake of understanding, this is the junction. Let's say this is the entire esophagus. The esophagus is now going to continue into the stomach. From the stomach, it continues into duodenum. From the duodenum, it is going to go into jejunum. From the jejunum, it goes into ileum. The ileum goes into the terminal ileum. In the terminal ileum, it is going to have an appendix at the tip. Then you have the cecum, and this cecum continues as the ascending colon. You can see from here onward, you see the ascending colon is going to go down. It goes to hepatic flexure. From there, it is now going to go into the transverse colon. Now, from the transverse colon, it is now going to go into the descending colon. So this is the continuation into the descending colon. From here, you have the sigmoid colon. From the sigmoid colon, you have the rectum. And at the end, it is going to go into the anal canal. Now, this is the entire depiction of our GIT. When you look from here, it starts from the esophagus. It goes into the stomach, then into the duodenum, then to jejunum, then to the ileum, ascending colon, descending colon, sigmoid colon, rectum, and the anal canal. This is what we have. Now, what is there for us to understand? That the entire esophagus is lined by the squamous epithelial cell, except for the last two part. As you can see, the last two part is lined by the columnar epithelium. The last two part is lined by columnar epithelium, and you will see from here onwards the entire GIT. From here onwards, the entire GIT will be lined by your columnar epithelium. Let it be your large bowel, let it be your small bowel, let it be your appendix, let it be your colon. Anything it is lined by columnar epithelium all the way to the anal canal. But what you see, again, when it comes down to the anal canal, the last part, that is the last 2 centimeters of the anal canal, goes back and now develops into squamous epithelium. Right, the last 2 centimeters is lined by your squamous epithelium. Now, when you look at this, in the entire GIT, only there are 2 sites of the squamo-columnar junction, right? So this is the first site of the squamo-columnar junction. This is the first site of the squamo-columnar junction. This is the first site of the squamo-columnar junction, and there is another site of the squamo-columnar junction which is at the level of anal canal. So another site of the squamo-columnar junction, another site of your squamo-columnar junction is seen at the level of anal canal, right? So you have 2 squamo-columnar junctions. One is at the level of esophagus. One squamo-columnar junction is present at the level of esophagus. Another one is at the level of your anal canal. Now, the squamo-columnar junction of the esophagus is what we call it as the fancy Z line. Now, this is what we call it as Z line. So, Z line is, or Z line is nothing but the squamo-columnar junction of the esophagus. The squamo-columnar junction of the anal canal is what we call it as dentate line. So, when we study about the anal canal, you will notice that dentate line plays a very important role. So, dentate line is the squamo-columnar junction. The dentate line is the squamo-columnar junction of the anal canal, whereas the Z line is the squamo-columnar junction of the esophagus. Why do you want to know this about it? It is because of a very simple concept that any malignancy that is going to arise, above the level of the Z line, any malignancy that arises above the level of Z line, the most common variant here has to be your squamous cell carcinoma. It has to be your squamous cell carcinoma. So when they say what is the most common malignancy that arises in the esophagus, especially above the level of Z line, it is only possible to have the squamous cell carcinoma. Any malignancy that is going to arise between the Z line and the dentate line, any malignancy that arises between the Z line and dentate line, everything is lined by columnar, and in columnar, the only malignancy that you can have is adenocarcinoma. So here there will be only adenocarcinoma. Right, so between the Z line and the dentate line, the malignancy that usually occurs is going to be adenocarcinoma. And again, when it goes below the dentate line, the most common variant here is also going to be your squamous cell carcinoma. It is going to be your squamous cell carcinoma. So nothing spectacular about it. This is a small concept that they keep asking you again and again. Now just think about it in this context. What is the most common malignancy of the esophagus? Obviously, it is going to be squamous cell carcinoma. Why? Because it is lined by squamous cell alone. What is the most common type in your stomach? Adenocarcinoma. In your small bowel, adenocarcinoma. Large bowel, adenocarcinoma. Sigmoid colon, adenocarcinoma. Rectum, adenocarcinoma. Why? Because it is lined by your columnar epithelium cell. When it comes down to anal canal, again you have the squamous epithelium. Hence, it is the most likely malignancy. So, most common malignancy of anal canal is squamous cell carcinoma. There is no brainer in this. You don't need to cram it up. If you understand this concept, you are sorted. And this is what you need to understand with respect to the epithelial component. Such a small concept, but then it plays a very pivotal role to understand that what form of malignancies can you expect in the various GI tract. I hope you're clear with that, right? Now, if you've understood, let's go to the muscular anatomy of the esophagus, right? So this is the basic orientation of the esophagus that you need to keep. Now, as you go down, we talk about the various divisions in the esophagus that we are going to encounter. So again, we go across here. This happens to be the cricopharynx. It continues here. This happens to be the esophagus, and the esophagus is going to continue all the way across. It pierces the diaphragm. As it pierces the diaphragm, it is now going to be continuous with the stomach, and this is what we've been telling across. Now, when you talk about the diaphragm, just for the sake of understanding, I'm just creating the diaphragm here. So this is where you see the diaphragm is present and esophagus is piercing the diaphragm. I'll superimpose a lot of information, but for now, let's understand the muscular component of it. So what we do is we divide the esophagus into various components, right? So the esophagus, which is present inside the neck or in the neck, we call it as the cervical esophagus. So from the cricopharynx, you will see that approximately 5 centimeters from there, this is what we call it as the cervical esophagus. This part is what we call it as the cervical esophagus, right? Now, from the cervical esophagus, the thoracic esophagus starts. The thoracic esophagus is divided into the upper 1/3, the middle 1/3, and the lower 1/3. This is the thoracic esophagus. We divide into upper 1/3 of the thoracic esophagus. This is the upper, or we can say simply say upper thoracic esophagus. We call it as the upper thoracic esophagus. There's the upper thoracic esophagus. Then you have the middle thoracic esophagus. Then you have the lower thoracic esophagus, right? So you divided them into cervical esophagus, upper thoracic esophagus, middle thoracic, and the lower thoracic esophagus. Now, once it pierces the diaphragm, from the diaphragmatic level all the way to your gastroesophageal junction, from the diaphragmatic level all the way to the gastroesophageal junction, this is what we call it as the abdominal esophagus. This is what we call it as the abdominal esophagus, right? Now, all these are very, very important. All these are very, very important. So these are the divisional status that you have. On one end, you have the cervical esophagus. On one end, you have the cervical esophagus. Then it goes into upper thoracic, middle thoracic, lower thoracic, and the abdominal esophagus. Now, the question is, how do you know or how do you calibrate this distance? So we are going to measure this from the oral cavity, that is from your incisors, right? So when you start measuring it from the incisors, you will notice that the beginning of your esophagus, which is here, the cricopharyngeal junction will be starting at a 15 centimeter mark. Next, you see that the cervical esophagus will end at a 20 centimeter mark. So I can say the cervical esophagus is 5 centimeters in length, right? Your cervical esophagus is 5 centimeters in length. Now, from the 20 centimeter mark, it will start your upper thoracic esophagus. The upper thoracic esophagus will end at a 25 centimeter mark. This is also going to be 5 centimeters in length. The longest will be your middle. The longest will be, the components will be your thoracic esophagus. So from 20 to 25 centimeter mark, from a 25, this is your 30 centimeter mark. This is going to be your 30 centimeter mark. So this is your middle esophagus or the middle thoracic esophagus. This is also going to be 5 centimeters in length. It is going to be a 5 centimeters in length. Now this is your lower part or lower thoracic esophagus. The lower thoracic esophagus will end at a 40 centimeter mark. Now as it ends at a 40 centimeter mark, the lower esophagus or the lower thoracic esophagus is 10 centimeters in length. So if I say among the thoracic esophagus, which is the longest? Which is the longest? The answer is going to be the lower thoracic. And last, from 40 to 45 centimeter mark, you have your intra-abdominal esophagus, which is going to be 5 centimeters in length. Now, this is the latest division that you should know with respect to esophagus. No matter where you read it, how you read it, this is how the esophagus is now divided. So when you do an upper GI endoscopy, your gastroenterologist or your medicine guy will always tell you whether it's looking at the cervical esophagus, the upper thoracic, the middle thoracic, the lower thoracic, or the abdominal esophagus. Each part is precisely put, right? Each part is precisely put in their own location. So you know these are the divisional status. Now, where are you measuring all these? Like I'm saying a 15 centimeter, 20, 25, 30 from where? So this all starts from the oral cavity. Now, let's say this is the oral cavity of the patient. This is your upper incisors. This is your lower incisors. and all these are basically your endoscopic markings. So what I'll do is I'll take the endoscope, I will put the endoscope in the mouth, and then I will put it across here. Now as the endoscope goes into the abdomen, as it passes through, it will give me a reading. So on an endoscope at a 15 centimeter reading, I know it is started at cricopharynx. At a 20 centimeter reading, my endoscope has now passed the cervical esophagus. At a 25, it has passed upper. At 30, it has passed the middle. At 40, it has passed the lower. And at 45, it has passed the gastroesophageal junction. So all these measurements are going to be from the oral cavity, precisely from where? It is going to be from the upper incisors. You measure all this from upper incisors. So all these measurements that you have, if I have to put them in a prospective so that we don't get confused. Right. So all these is going to be from the oral cavity. So you measure from the upper incisors, like the lower border of the upper incisor. As the scope passes through, you'll get the readings here. Now at that reading, you know at what particular point you're present. Okay. Now the same thing is utilized to understand what are the muscular components of it. What are the muscular components of it? I'll just expand on the same context. Now in the muscular component of the esophagus, again we'll replicate the same diagram, nothing changes. This is the cricopharynx, which is going here. From here you have the esophagus. This is the esophagus that you have. Now this esophagus is going to be continuous with the stomach, and this is how it has gone across here. We told the diaphragm is going to be pierced, so this is the diaphragm where it is going to be piercing. The esophagus will pierce the diaphragm and then go into the abdomen per se. Now as we have discussed it, that this is the cricopharynx. The first 5 centimeters is going to be your cervical esophagus. Then you have the upper 1/3. You have the middle 1/3 and the lower 1/3 of the esophagus, right? So this is the upper esophagus. This is the middle thoracic. So upper thoracic, middle thoracic. As you know, the lower thoracic is longest, and this is your intra-abdominal. This is your intra-abdominal. This is your cervical esophagus. This happens to be your cervical esophagus. Nothing spectacular, same thing, but I've given you in a very pictorial form. You will notice that the cervical esophagus is purely made up of the skeletal muscle. It is purely made up of the skeletal muscle, right? Then you will notice that the upper and the middle thoracic part, few of it is made up of the skeletal muscles, and few of it will be made by smooth muscles. You'll say this is the skeletal orientation, and then you say this is the smooth muscles. So the upper and the middle thoracic will have a mixed one. From here onwards, you see the entire GIT, not only the esophagus, the entire GIT will be made up of smooth muscles. The entire GIT from here on would be made up of smooth muscles, irrespective of what you're looking at. Let it be stomach, let it be small bowel, let it be large bowel. Every single component from here on would be made up of smooth muscles. So this muscular architecture is also very, very important for us to understand, because when you're making an anastomosis, if the muscular architecture are alike, the anastomosis sits well. If the muscular architecture is poor, obviously when you're trying to make an anastomosis, that is you're trying to combine. अगर आप जोड़ने की कोशिश कर रहे हो, एक skeletal एक smooth है, तो obviously वो contraction में ना, that peristalsis, that movement and that contraction will not sync together. तो anastomotic site पे leakage और incidence of having strictures are much more higher. लेकिन अगर दो smooth muscles और दोनों को जोड़ रहे हो, it is quite easy for to do it. तो यहाँ पे problem नहीं होता है. तो आपको कैसे पता चलेगा कि आप skeletal जोड़ रहे हो या फिर you're anastomosis with smooth muscle? This is what you have to look for, right? So when you look at it, when you come across the cervical esophagus, this is going to be made up of the skeletal muscle. This is skeletal muscle. From here, it is your mixed muscles. And from here on, it is only going to be the smooth muscle. Here on, it is going to be smooth muscles, right? You see the cervical esophagus is only made up of skeletal muscle. The upper and the middle 1/3 of the esophagus, that is thoracic esophagus, is a combination of both. So when I say mixed muscles, in a mixed muscle, it is going to be involving both skeletal as well as smooth muscle. And from here on, it is entirely going to be smooth muscle. From here on, it is purely or entirely going to be smooth muscles. So this transition is also very, very important. So this transition is also very, very important for us. Now that you know all the transitions which are present here, and we have understood how the constrictions, how the division is there. Now a very important concept of esophageal constrictions, right? So talk about what are the different esophageal constrictions that you have. So we have something called as physiological or the normal anatomical esophageal constrictions. So we talk about the normal constrictions, in esophagus. To talk about the normal constriction in esophagus, right? So when you try to understand the normal constriction in the esophagus, let's analyze this. Okay? Same thing, nothing spectacular. You have the cricopharynx which is present here. This is going to continue with the esophagus. So this is how the esophagus is going to present. Now esophagus is going to run across here, and this is where you have the stomach. And we all know that it is going to be piercing the diaphragm, and then it is going to go into the abdomen. So this is the basic objective that we have. So nothing has changed. The same orientation is there. Now we have to find where the constrictions are present. Now the first constriction will be present at the beginning of the esophagus itself. So this is at cricopharynx. Right. So the first constriction is at the level of cricopharynx itself. Now the second constriction, you will notice that there is a blood vessel that is going to originate, and it is going to override the esophagus, and it is going to go like this. Now this blood vessel which is going to override the esophagus and travel left of it, needless to tell you, this is going to be your abdominal aorta. Sorry, this is going to be your aorta. So as you can see, the aorta is going to cross. As the aorta is going to ride on top of the esophagus, such a muscular, high pressured vessel, when it goes on top of the esophagus, it will compress the esophagus. So the second constriction will be seen at the level of arch of aorta. It is seen at the level of arch of aorta. Now you see just anterior to it, which is here, you see the main trachea is going to be running. Now this is going to bifurcate into two main components. That is your right main bronchus and the left main bronchus, which is going to be going across it. So obviously when the trachea is going to come across and it is going to ride on top, it is going to go over the esophagus. Now as it goes over the esophagus, it is now going to compress the esophagus again, right? So trachea is passing on top of the esophagus. Obviously it is going to constrict. Obviously it is going to constrict the esophagus. The third constriction that you will see here is going to be when the left main bronchus, when the left main bronchus, when it is going to override. You see the left main bronchus, it is overriding the esophagus. This is the third constriction. Now the fourth constriction that you will see when the diaphragm is piercing the esophagus, or the esophagus piercing diaphragm, this is at the level of diaphragm. This is at the level of diaphragm, right? So these are the four natural constrictions which are going to be present. The first one is going to be the cricopharynx. The second one is going to be arch of aorta. The third one is going to be left main bronchus, and the fourth one is going to be at the level of diaphragm. Again, as we all know, these are the one which are going to be relevant when you're doing an upper GI endoscopy. This is the oral cavity. This happens to be the upper incisors. And I am going to introduce the endoscope. So when we introduce the endoscope is going to go across here. Now as it passes, this is the first side they will see. This is the second side they will see the constriction. This is the third side they will see the constriction. And the last one, when it is entering into the abdomen, this is the fourth constriction, right? You will measure all these constrictions with respect to the esophagus. The first constriction that you will see will be at a 15 centimeter mark from the upper incisors. Now the second one, see, there is a difference between the arch of aorta and left main bronchus. Together we can say that they are seen at a 25 centimeter mark, and the last one, that is diaphragm, will be seen at a 40 centimeter mark. Right? Okay. Somebody is asking what? Kya puch rahe beta? Sir, the constriction due to the left bronchus is below the one caused by aorta. Beta, aorta will cause above this, no? तो पहले aortic constriction आएगा, उसके बाद left main bronchus का constriction आएगा ना? So aorta is overriding this. So your arch of aorta, when it goes on top of the esophagus, that is where it is causing the constriction. Left main bronchus उसके नीचे. ठीक है? The left main bronchus is going to be below that. Raman says, good evening sir, please upload. बेटा hernia notes हमने कितनी बार तो upload कर दिया है. If you feel it is not done, I'll do it live once the lecture is done. No, we'll extract all these notes along with the hernia notes, put it on the Telegram right away. ठीक है? चलो. So these are the natural constrictions which are going to be present. So from the cricopharynx all the way to left main bronchus, why it is important is whenever a baby or an adult, when they ingest a foreign body, these are the possible sites where it is going to get lodged. So obviously whichever is the narrowest one will get lodged more. So the narrowest site among all the given components, it is a cricopharynx, which is considered to be the narrowest site of the esophagus. This is considered to be as the narrowest site of the esophagus. So usually when the foreign body is going to come, no, it usually gets stuck at the level of cricopharynx. It usually gets stuck at the level of cricopharynx, right? So this is with respect to, this is with respect to the normal constrictions, right? So we now have the sound understanding about how the esophagus is divided into various parts, what are the muscular architectures, and what do you have as a normal constriction. What do you have as a normal constriction? Okay. Now, if you have understood this, okay, just for the sake of completion, I don't want to overburden you with information, but then because we're reading, we'll read it completely. So when I say cricopharynx, it will be seen at a C6 level. Arch of aorta will be seen at a T3 level. Left main bronchus, when it's going to arch, it is going to be seen at a T5 level. Diaphragm is going to pierce by esophagus at T10 level. No points for guessing. Okay? So if you want to remember, just remember the vertebral, corresponding vertebrae also. The cricopharynx is going to be pierced at C6, the arch of aorta is T3, the left main bronchus at T5, left main bronchus, your diaphragm is going to be at T10. If you have any doubt, no, diaphragm कौन से level पे pierce कर रहा है, just write esophagus with O. So O-E-S-O-P-H-A-G-U-S. So you look at the number of letters which have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you can see esophagus is a 10-lettered word. So obviously it is going to pierce the diaphragm at T10. Right? It's a 10-lettered word. So obviously it is going to pierce the diaphragm at T10. So that's an easy way to remember it. I'm not a huge fan of mnemonic, but sometimes it helps, right? So this is what you have to remember. Clear? Yeah. Now, let's move to the esophageal, I would say gut wall anatomy, right? We'll talk about the anatomy of the gut wall. Very, very important. Every single concept that we will build, which is going to be relevant physiologically later on, is going to be derived from this component, right? So this is going to be the anatomy of the gut wall. So we'll see what do you have. When you look at the gut wall, the innermost layer of the gut wall is what we call it as mucosa, right? So the innermost layer of the any GIT wall is going to be your mucosa. Surrounding the mucosa, you have your submucosa. Surrounding the submucosa, you have the inner circular muscles. So this is the depiction of the inner circular muscles. And outside this, what do you have? You have the outer longitudinal muscles. So you have the inner circular muscles, and then you have the inner circular muscles, and then you have the outer longitudinal muscles. So you have the inner circular muscles. So this is your inner circular muscle which is present, and these are your outer longitudinal muscles. These are your outer longitudinal muscles. Now the outermost layer, which is going to vary from component to component, but I'll just draw it down. This is what we call it as the outermost layer of the gut. The outermost layer of the gut. So when you look at the innermost layer is the mucosal surface, and these are your mucus producing cells. They produce the mucus, they have the squamous epithelium, they have the columnar epithelium. So the epithelial layer will be present on this, and this is what we call it as the mucosal layer of the esophagus, right? So the innermost layer is going to be your mucosa. The innermost layer is going to be the mucosa, which is here. Under the mucosa, what do you have is your submucosa. So this layer which is present here, this is your submucosa. This happens to be your submucosa. Then you go down here. This is your inner circular muscle. This happens to be your inner circular muscle. This happens to be your inner circular muscle. This is your outer longitudinal muscle. This is your outer longitudinal muscle, and the outermost layer which is present here. Now you need to understand the outermost layer. It depends where exactly you're looking at, right? So the same thing in esophagus will be called as adventitia, and in the abdomen it will be called as the serosa. Sorry. So either you can call it as adventitia, that is the outermost layer, or you can call it as serosa based upon where you have. Now the reason I'm telling you is, when you look at the serosa is a fancy name to tell you that we are talking about visceral peritoneum, right? So serosa is a fancy name to tell you that we're talking about visceral peritoneum. And we all know peritoneum is present inside the abdomen, not in the thorax. So esophagus is in the thorax. So thorax में peritoneum कैसे आएगा? जब peritoneum आएगा नहीं तो आप serosa कैसे बोलोगे? Serosa is nothing but visceral peritoneum. So visceral peritoneum is present only in the abdomen, or the organs which are present inside the abdominal intra-abdominal organ. अपना esophagus तो thorax में. So thorax में you cannot have the peritoneal covering on top of it. So you will have only the adventitia, the fibrous layer or the outermost layer of the esophagus is called as your adventitia. और फिर आपसे पूछा जाता है serosa is absent in. Beta, serosa is absent in wherever it is not in the abdomen. No, esophagus में serosa absent हो जाएगा, rectum में absent हो जाएगा, anal canal में absent हो जाएगा, क्योंकि rectum anal canal passes through the pelvic diaphragm and goes outside. They are also not in the abdomen. ठीक है? So whichever organ is intraperitoneal, those organs will have this covering, which is the outer covering, called as serosa. It's a fancy name to call it a visceral peritoneum. Right now we're dealing with esophagus, which is in thorax. So esophagus में serosa नहीं बोलोगे ना, क्योंकि peritoneum तो है नहीं. आप क्या बोलोगे उसको? adventitia बोलोगे. End of discussion. इतनी सी बात है. इसके लिए इतना हुआ बना के रखा होता है. Nothing, right? Serosa is visceral peritoneum. Visceral peritoneum will be present inside the abdomen. अभी मैं abdomen में हूँ ही नहीं, मैं तो esophagus में हूँ. esophagus thorax में, अगर esophagus thorax में है, needless to tell you कि वहां पे serosa हो ही नहीं सकता ना. End of discussion. अब बात करते हैं इसमें important चीजें क्या. Now you will see that the entire component of this or the gut wall will be run by two important neuronal plexuses. One that is present in the submucosa. These are called as the submucosal neuronal plexus, and one that is present between the junction of the circular and the longitudinal muscles, right? So there are two neuronal plexuses which are present. One which is present in submucosa and one that is present between your inner circular and the outer longitudinal muscle. Now one that is present here, the submucosal neuronal plexus. This is what we call it as the submucosal neuronal plexus. Now this submucosal neuronal plexus is what we call it as the Meissner's plexus. This is what we call it as the Meissner's plexus. These are what we call it as the Meissner's plexus. Now they are present in the submucosa. Then you see that these are the one which are present between the inner circular and the longitudinal muscles. So these are what we call it as the muscular neuronal plexus. They're called as the muscular neuronal plexus. Now this muscular neuronal plexus is what we call it as myenteric. It is called as the myenteric plexus. The other fancy name for your myenteric plexus, it is also called as the Oesophagus plexus. They're also called as the Oesophagus plexus. So this is what we call it as the myenteric plexus, or you can also call it as the Oesophagus plexus, right? So usually they'll ask you what is the location. Raman says 36 to 44 hernia notes have been uploaded, 44 and 42nd, only 2 of the 9 lectures, rest 7 not. Raman noted, beta, I will do it. Audio is audible from only one side. Ye kya hai beta? Is audio clear? Is the audio clear? Audio clear, audio clear. Clear enough? Sorted. Okay. Now, when they talk about these neuronal plexus, they ask you what are the two neuronal plexus here? We have the submucosal, that is Meissner's, another one is myenteric. Now, when you talk about Meissner's plexus, Meissner's में ना इतना याद रखना 2 S हैं. Meissner's has 2 S, so it is submucosa. And myenteric, my means muscle, enteric means bowel. So muscle के bowel के muscle part में जो है वो myenteric plexus है. There are nothing but your Oesophagus plexus. Now, when you look at this, obviously the function is quite predictable क्योंकि Meissner's plexus submucosa में है. Submucosa में क्या होता है? It is responsible for absorption. It is responsible for absorption and secretion. So whatever is going to get absorbed and secreted in the gut wall, it is controlled by your Meissner's plexus. Now, having known this, another important point, Meissner's plexus are poorly developed. Meissner's plexus are poorly developed in esophagus. Now, because they're poorly developed in esophagus, आज तक आपने कभी कुछ सुना ही नहीं होगा कि esophagus से कुछ absorb हो रहा है, कुछ secrete हो रहा है. There is no absorption or there is no secretion from the esophagus that is happening क्योंकि esophagus में Meissner's plexus are poorly developed, वो develop हो ही नहीं पाए. They are not being integrated, they are not been well developed. So obviously they are not able, they are not capable of absorbing or secreting. So it just acts as a mechanical tube. कि खाया मुंह में गया पेट में, खाया मुंह में गया पेट में. The esophagus is only a channel to do that. No absorption, no secretion. Esophagus बोलता है जा, नहीं करते काम, जो करना है कर ले. Meissner's plexus है ही नहीं. लेकिन हमने क्या किया? हमने बोला भाई myenteric plexus तो है, अब ये मसल में है. अब क्या होगा? Muscle is going to contract, and every time the muscle contracts, relax, क्या होगा? The contraction and relaxation will cause propulsion of the food in the forward direction, and hence your myenteric plexus are responsible for peristalsis. The myenteric plexus are responsible for your peristalsis. So Meissner's plexus are responsible for absorption, secretion. Myenteric plexus are responsible for your peristalsis. Now, there's a very basic concept. थोड़ा ध्यान से सोचो. Put your head down to it. Why do you have two orientation of muscles? Why do you have a circular muscle? Why do you have a longitudinal muscle? क्यों पूरा सर्कुलर नहीं है, क्यों पूरा लॉन्गिट्यूडनल नहीं है? यू हैव टू डिफरेंट ओरिएंटेशन ऑफ मसल्स. इसका भी एक रीजन है. एवरीथिंग इज सो ब्यूटीफुली स्टिच्ड टुगेदर. यू नीड टू अंडरस्टैंड. नाउ व्हेन आई से देयर आर टू ओरिएंटेशन ऑफ मसल, आई एम जस्ट गोइंग टू मेक इट डाउन फॉर इट. लेट्स से दिस इज द इनर सर्कुलर मसल. वी आर टॉकिंग अबाउट दिस इज द इनर सर्कुलर मसल दैट इज प्रेजेंट, एंड लेट्स से दिस हैपेंस टू बी द आउटर लॉन्गिट्यूडनल मसल. This happens to be the outer longitudinal muscle. I told you there are two orientation of the muscles which are present. You have the inner circular muscle and there is the outer longitudinal muscle. My question was quite simple to you. Why do you have two different orientation of muscles? Soumya, you are absolutely correct. One is to grip, another one is to propel. Now imagine every time you eat the food, the patient is going to consume the food. The food is going to come into the lumen. तो food lumen के अंदर आ गया. ठीक है. नाउ इमेजिन अगर कोई पकड़ने वाला ही नहीं होता तो पूरा फूड ऐसे ही फिसल जाता. तो आई वांट, सी ईसोफेगस में नहीं हो रहा ना अब्जॉर्प्शन सेक्रेशन, लेकिन पूरे गट में तो हो रहा है. और ये जो वॉल की एनाटॉमी है, इट इज गोइंग टू बी कंसिस्टेंट थ्रू आउट द गट. नाउ बिकॉज इट इज कंसिस्टेंट थ्रू आउट द गट, imagine that every single time it goes into your small intestine, large intestine or wherever, I don't want the food to generally pass away. I want the food to stay stop at some place so that some absorption, some secretion can happen and then it moves slowly. तो इसको रोकेगा कौन? इसको रोकेंगे हमारे circular muscles. So the minute what is going to happen is, as soon as it comes, the circular muscles are going to contract. Now, as the circular muscles are going to contract, what is going to happen? These circular muscles which are here, now they are going to grip it. Now, as they grip it, now because they're contracting, you can see, I can show the circular muscle contraction in this fashion. So, as the circular muscles contract, now they are gripping the food. So, circular muscle contract करके food को पकड़ लिया. Now, this is to grip the food. Now, once they have done the absorption secretion, जैसे ही circular muscle ने grip किया, the food में absorption as well as secretion continues to happen. तो जो काम था वो हो गया absorption secretion का. अब मुझे चाहिए नहीं गन्ने का रस चूस लिया, गन्ने का क्या करोगे? आगे फेंकोगे. How will you do that? Now you want your longitudinal muscles to contract. जैसे ही आपके longitudinal muscles contract करेंगे, the minute you see your longitudinal muscles are going to contract, as your longitudinal muscles are going to contract, they are now going to propel the food in the forward direction. Now, as you see, as these muscles are going to contract, they will force the food to move forward. तो ये ऐसे दबेगा, ऐसे. When it compresses, it is now going to move forward. Right? Yeah. So as you can see, the circular muscles are going to grip. They are going to hold longitudinal muscle when they grip. They propel the food in the forward direction. So remember, your inner circular muscles, they grip the food, and the outer longitudinal muscles, they propel the content or food in forward direction. तो longitudinal muscles का काम है कंटेंट को आगे प्रोपेल करना, सर्कुलर मसल्स का काम है कंटेंट को ग्रिप करना. इज दैट क्लियर? ठीक है, बड़ा सिंपल सा कॉन्सेप्ट है बट वेरी 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 इंपॉर्टेंट. ठीक है, सो दिस इज द बेसिक कॉन्सेप्ट ऑफ योर मायोट्रिक एज वेल एज मीजनस फ्लक्सस. कहानी खत्म नहीं हुई है, कहानी अभी और भी बहुत है. फिर हमारी आती है ब्लड सप्लाई के. रिमेंबर द एंटायर वास्कुलर पूल ऑफ द गट will be present in the submucosa. From here, it is going to supply blood to every nook and corner. So vascular supply or the vascular pool is formed in the submucosa. From here, it is going to supply blood to mucosa. It is going to supply blood to the circular longitudinal muscles as well as your adventitia. So every single component which is going to derive the blood, it is going to be derived from your inner submucosa. So जो पूरा blood supply which is running across here, so every neuronal plexus that draws its blood supply will also be drawing it from your submucosa itself, right? So the vascular pool of your gut, we say the vascular pool of the gut is in the submucosa. The vascular pool is in the submucosa. Swastik, it is correct. So every time the longitudinal contracts, the circle has to relax. Then only the food will go forward. Now, pakad ke rakho, aise jayega. It's a rhythmic contraction. It goes circular, contracts, long. So it's like this. So you need to imagine it this way, that this is the longitudinal muscle, this is the circular muscle. ठीक है, ये longitudinal circular. पहले circular contract किया, then ये relax किया, फिर longitudinal, then circular, फिर longitudinal. It goes in this. So it goes circular first, relaxes longitudinal. Longitudinal goes circular. Circular goes longitudinal. So it goes like this, right? So circular longitudinal, circular longitudinal, circular longitudinal. So it will propel the food in the forward direction. ठीक है, तो पहले circular, फिर longitudinal. Circular relax करेगा, longitudinal contract करेगा, फिर circular contract करेगा, longitudinal relax करेगा. So it goes this. ठीक है, तो ये contract, ये relax, ये relax, ये contract, ये relax. So it goes in this particular fashion. ठीक है, so the vascular pool will come from the submucosa. Now, why this is important? This is extremely important because whenever you have any GI bleeds, we have significant bleeds and insignificant bleeds, minor bleeds and major bleeds. Now, if the breach is only in the mucosa, sir, mucosa में damage जब bleed करेगा तो minor bleed ही होगा ना. लेकिन अगर वही breach बढ़ते सब mucosa तक चला गया, सब mucosa में breach हो गया, As long as the breach or erosion or injury is limited to mucosa, it will bleed, but not significantly. The minute the breach goes bada, 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 and it goes into the submucosa, and bam, it is going to break your vessels. Now, as it breaks its submucosal vessel, it is going to bleed significantly, and hence all significant GI bleeds will only present to you when the breach is all the way to the submucosa. Do not forget that. Again, a very, very important but yet a very beautiful concept. Okay? So this is in general about the esophageal wall anatomy. Okay? Are you clear with this? Right? Can we move on? So far, any doubts? कोई सवाल, कोई शक? है ना? Sometimes I also look at my diagrams, you know, I'm like, I do a decent job. Like, come on. है ना? इतना प्यार से कौन बनाता है यार? मतलब कभी कभी मुझे भी लगता है मेरे नोट्स देख के ना, मेरे वीडियोस देख के कि भाई कोई हमें भी पढ़ा देता है ऐसे. ठीक है? ओके, जोक्स अपार्ट, बट देन क्रेडिबिलिटी यार थोड़ा तो, राइट? चलो, सो टॉक अबाउट esophageal sphincter. We're talking about the esophageal sphincter, right? Now, when you talk about esophageal sphincter, पहले तो ये समझ लो कि sphincter और valve में फर्क क्या होता है. हमेशा ना यही सवाल लेके आया तो कि sphincter क्या होता है, valve क्या होता है. So let's understand the difference between a sphincter and a valve. दोनों के बीच का फर्क क्या है? What is the difference between the sphincter and the valve? Now you need to understand, sphincters are governed by pressure. We say the sphincters are predominantly, they are controlled by pressure. They're controlled by pressure. Valves, they are controlled by the direction of flow. They are controlled by the direction of flow. So what do you mean by this? Let's understand. Now imagine हमारे पास दो lumens हैं. We'll take two lumens. This is your lumen number 1 and this is your lumen number 2. In lumen number 1 we have sphincter and lumen number 2 you have valve. So the sphincter, when you look at it, the sphincter is going to be something like this, right? Just for the sake of understanding, we are creating it. This is how a sphincter would look like, right? Whereas when you talk about valve, I'm going to create the valve. It's a mechanical structure which will be present like this, right? So when you talk about it, the sphincters are going to be present in a way that it looks like a mechanical propeller. We'll talk about it. Valve, on the other hand, is only be controlled, driven by the flow and the direction only, nothing more than that. What do you mean by this? Let's decode this. Sphincters का ना, we say, इनका खुद का कोई ईमान नहीं होता. जो प्रेशर देगा खुल जाएंगे. अगर ऊपर से प्रेशर आया, if the content which is coming down here exerts more and more amount of pressure and there is a threshold pressure at which the sphincter relaxes, जैसे ही प्रेशर बढ़ेगा, you will notice that these sphincters are going to relax, और जैसे ही sphincter relax करेगा, the content will be able to move in the forward direction. Same thing what is going to happen is, अगर flow नीचे से आना शुरू हुआ, let's say there is something flowing from the lower side, again it will exert pressure on the sphincter, and once the threshold of the sphincter is reached, again this is going to relax, and once it relaxes, the content is going to move upwards. So as you can see in the sphincter, the content can move both ऊपर नीचे, it can move up and down. It only depends कि कौन कितना pressure देता है, उस pressure में sphincter give away कर जाता है. So imagine it this way, that this is the sphincter. प्रेशर ऊपर ज्यादा है, स्फिंक्टर गया नीचे चला गया, कंटेंट बंद हो गया वापस. अगर नीचे प्रेशर बढ़ गया, नीचे से प्रेशर बढ़ा, आगे खुल गया तो ऊपर आ गया कंटेंट. सो द स्फिंक्टर्स आर ओनली गोइंग टू बी कंट्रोल्ड बाय द प्रेशर. जिस देखो स्फिंक्टर का है, इट्स लाइक अ टोल गेट. 25 रुपए है, दो जाओ, कहीं से भी इधर से भी आ रहे हो 25, उधर से भी आ रहे हो 25, बस 25 रुपए दे दो. सेम वही है कि लोअर इसोफेजियल स्फिंक्टर और अपर इसोफेजियल स्फिंक्टर जो भी है, स्फिंक्टर्स का जो है प्रेशर पे है. अगर आप प्रेशर डालोगे स्फिंक्टर खुल जाएगा, कंटेंट मूव कर जाएगा, प्रेशर अगेन स्फिंक्टर क्लोजेस. इफ द pressure below the sphincter is more, again it opens up, the content moves up, it closes. So sphincters are only going to be controlled by pressure. It is only going to be controlled by pressure. Valve on the other hand, valve बोलता है भाई हमारे में ईमान है, ठीक है. तो वो क्या है, valve बोलता है कि देखो जैसे फ्लो आएगा, as flow comes it will allow because valves are opening, ठीक है, ये अलाउ कर दिया. ऑन दी अदर हैंड कि उल्टा फ्लो जब चलेगा, बोलता ठीक है अगर एक साइड से आ सकता है तो इधर से भी चलते हैं. तो व्हेन द फ्लो विल स्टार्ट गोइंग इन अ रेट्रोग्रेड फैशन, इट रीचेस टू द वाल्व. वाल्व सेज थैंक यू, बाय बाय, टाटा, यू आर नॉट अलाउड. सो द कंटेंट विल रिवर्ट बैक. As long as the integrity of the valve is maintained, as long as the integrity of the valve is maintained, the content can never flow up. एक ही डायरेक्शन में चलेगा, जिस डायरेक्शन में चलना है उसी में रहेगा. तो स्फिंक्टर और वाल्व में क्या फर्क है? स्फिंक्टर विल अलाउ अ बाई डायरेक्शनल फ्लो, इट इज ओनली डिपेंडेंट ऑन प्रेशर. जितना प्रेशर लगता है दे दो, खुल जाएगा. वाल्व बोलता है भैया हमको प्रेशर उषा से नहीं पड़ता, कोई वैल्यू नहीं है, हमारा एथिक है, ठीक है. वाल्व बोलता है कि मैं बस एक डायरेक्शन में अलाउ करूंगा तो एक डायरेक्शन में अलाउ करूंगा. आई वोंट अलाउ अ रेट्रोग्रेड फ्लो. अ रिवर्सल ऑफ फ्लो इज नॉट पॉसिबल until unless the valves are intact. So valves will allow a unidirectional flow, whereas your sphincters allow a bidirectional flow, and that's the carry home message. Remember, valves will allow sphincter will allow a bidirectional flow, whereas valves will allow a unidirectional flow. So हम जब GIT में बात करते हैं ना, स्फिंक्टर ही स्फिंक्टर है. अपर इसोफेजियल स्फिंक्टर, लोअर इसोफेजियल स्फिंक्टर, पाइलोरिक स्फिंक्टर, then you talk about anal sphincter. तो सारे स्फिंक्टर्स है, एक ही जगह वाल्व है, दैट इज आइलियोसिकल वाल्व. इसलिए बोलते हैं ना कंटेंट जब आइलियम से सीकम में चला जाता है वापस नहीं आ सकता, बाकी हर जगह वापस आ जाएगा क्योंकि स्फिंक्टर खुल तो जाएगा. एक्सेप्ट फॉर योर आइलियोसिकल जंक्शन जहां पे वाल्व है, इट विल अलाउ द कंटेंट फ्रॉम द आइलियम टू गो इनटू द सीकम, वो वापस नहीं आने देगा, वापस नहीं आएगा, वाल्व है, ठीक है. सो वाल्व विल प्रिवेंट अ रेट्रोग्रेड फ्लो, एज सिंपल एज दैट. नाउ कमिंग टू द esophageal sphincter. In the esophageal sphincter, we have two forms of the esophageal sphincter. One is what we call it as the upper esophageal sphincter. One is your upper esophageal sphincter, and another one is your lower esophageal sphincter. We have the upper esophageal sphincter and the lower esophageal sphincter. Now, to be very honest, the difference is the upper esophageal sphincter is actually a sphincter. That means this is an example of an anatomical sphincter. This is an example of an anatomical sphincter. Whereas the lower esophageal sphincter is actually not a sphincter per se. There's no structure which is making it behave like sphincter, but the mechanics is such that it behaves like sphincter. So hence this is what we call it as a physiological sphincter. This is what we call it as physiological sphincter. I'll explain you in a bit what do you mean by this. Now when we talk about the upper esophageal sphincter, to understand the upper esophageal sphincter, you need to understand a little bit of what is going on before that. So let's say this is the hyoid bone that you have. We have learned enough about it in our thyroid chapter. So this is the hyoid bone that you have, right? Below the hyoid bone, you have your thyroid cartilage. This is the thyroid cartilage. Below the thyroid cartilage, you have your cricoid cartilage. So this is the cricoid cartilage. And then you have, this is the trachea that is present across here. So nothing spectacular about it. So you have the hyoid bone, the thyroid cartilage, as well as the cricoid cartilage, right? Next, you see, you have our muscular tube, which is going across here. So from the cricoid junction, this is where the esophagus usually starts. So we'll say that this is the junctional status. So this is the junctional status from where the esophagus is going to begin. Let's say this is the esophagus. So we'll say the oropharynx, the cricopharynx, which is here, and then this is where the esophagus is going to run, right? Just for the sake of understanding, I'm just making this is the esophagus that you have. This is the upper part of the esophagus that you have. Now, when you talk about the upper esophageal sphincter, there is a muscular component which is going to make it behave like a sphincter. This muscle, which is going to start from the thyroid, that is thyroid cartilage, it is going to encircle your esophagus. It is going to encircle the esophagus and it is going to grip it, and it comes back and attaches here. It's like a circular component. It is going to circulate the esophagus, and then it is going to come attach onto the other side of the thyroid cartilage, right? So this muscular band, if you see this muscular band which is traveling, so this is the thyroid cartilage that you have. This is the thyroid cartilage which is going to be here. And you see the muscle that is attaching, the esophageal muscles, or you can say the muscular component which is present here. It starts from the thyroid cartilage, circles the esophagus, and then comes back. This is one muscle. This is what we call it as the thyropharyngeus. This muscle is what we call it as the thyropharyngeus muscle. This is what we call it as the thyropharyngeus muscle, and then it reverts from the other side and it anchors on here, right? So this is how the one particular set of muscle is coming. Another set of muscle which is going to be from the lower part, this is going to be your cricopharynx, which is coming like this. So these two set of muscles, when they contract, so obviously when they contract, imagine if these two set of muscles, when they contract, they compress the esophagus. When they compress the esophageal lumen is compressed and hence not allowing the content to move forward. And this is your upper esophageal sphincter. When you look at the upper esophageal sphincter, which is formed by the two muscles which are there. Does anybody know what are these two muscles? What are the two muscles that you have? These are what we call it as the inferior constrictors, right? They're called as the inferior pharyngeal constrictors. The two muscles which are present. Number one, this is your thyropharyngeus. This is your thyropharyngeus muscle, and this happens to be your cricopharyngeus muscle. The thyropharyngeus muscle and the cricopharyngeus muscle together is what we call it as the inferior pharyngeal constrictors. Together they're called as the inferior pharyngeal constrictors. These are your inferior pharyngeal constrictor. These inferior pharyngeal constrictors, when they contract the esophagus so hard that they grip it, and that gripping of the esophagus will make it compress. And obviously when you eat food, in the same context, I'll just continue across here. When you eat food, the food goes into the lumen, and as the lumen starts to contract, it will initiate peristalsis. No, that peristalsis will generate pressure inside the lumen, and that pressure is enough to relax the sphincters. The content will move forward. The minute it goes, again it compresses, esophagus remains closed, and this is your upper esophageal sphincter. This is your upper esophageal sphincter, is the anatomical orientation in this particular manner. I hope everybody is clear with this. This is a very, very important and beautiful concept. If you do not understand this, you will never understand the upper esophageal sphincter. The upper esophageal sphincter So when we say the upper esophageal sphincter, the concept is only this much. Itna samajh mein aa gaya, it is more than enough. You don't need to, bang your head against it. Lower esophageal sphincter, on the other hand, as I told you, it's a physiological sphincter. Now, because it's a physiological sphincter, you need to understand that how it behaves, or it is made to behave like sphincter. Again, nothing spectacular. We'll quickly run through it, this also. Right now, just for the sake of understanding, now we're going to concentrate on lower part of the esophagus. This is the esophagus. This happens to be the stomach, and this continues across here. Now, as you know, the lower part of the esophagus, the first thing you will see that there is diaphragm which is going to anchor around it. You will notice that as it pierces the diaphragm, there are these diaphragmatic muscles which are present, which are called as the crura, right? the crura of the diaphragmatic muscles, as it pierces through it, it is going to anchor the esophagus well. So it is basically the crural muscles. It is the crural muscles which are, so as it pierces, no, the diaphragmatic crura, it's like this. These are the two muscles and this is the esophagus. Now, as it goes in, the crura is compressing it. Now, when it compresses it, obviously it is going to compress the esophagus. The lumen is going to get compressed. So, ये जो muscle fibers हैं, diaphragmatic crural fibers हैं, ठीक है? So, esophagus is going and piercing through this, right? Now, the whole concept is, I have an esophageal lumen which is like this, okay? This is the normal lumen. Something is happening. Because of this, the lumen is getting compressed like this. So I need to find out that what is the reason or who is compressing the esophageal lumen so that it gets compressed. So esophageal lumen, when it gets compressed, it remains compressed. Now, only time or only way you can open this up when you exert adequate amount of pressure, and when pressure is exerted, it opens, the content moves forward and again it collapses back. My question is, who is doing this? कौन कर रहा है ये? कैसे लोग हैं ये? क्यों कर रहे हैं ये? नहीं पता. अब ये नहीं पता होगा तो कैसे पता चलेगा कि स्फिंक्टर है? बिहेव तो स्फिंक्टर की तरह ही कर रहा है, लेकिन कौन करवा रहा है is more important, and that is why you need to go through the physiological sphincter. Good evening sir, one doubt, during burn क्या dressing से पहले zone का coagulation? बेटा, any non-viable tissue has to be debride. हाँ आदित्य, all non-viable tissue, the zone of coagulation has to be debribed. Make sure it gets all the dead tissue out and then you go it on a regular basis for dressing. ठीक है, चलो. तो here, तो ऐसा क्या हो रहा है कि इसको स्फिंक्टर की तरह बिहेव करने की कोशिश हो रही है, ठीक है. The first thing you will notice, if I say what are the components or what is making it behave like sphincter. So the first component that it makes it behave like sphincter is the intra-abdominal. It is the intra-abdominal length of esophagus. It is the intra-abdominal length of esophagus. What do you mean by this? As we know, around 5 centimeters, around 4 to 5 centimeters of the esophagus is inside the abdomen. So what is the problem? The problem is, in the thorax we have a negative pressure, in the abdomen we have a positive pressure. नेगेटिव प्रेशर का मतलब है पुलिंग प्रेशर, पॉजिटिव प्रेशर का मतलब पुशिंग प्रेशर. तो ये पुशिंग प्रेशर क्या कर रहा है? इसको पुश कर रहा है. अब इसको पुश कर रहा है तो ये कंप्रेस हो जाएगा. अगर कंप्रेस हो जाएगा तो ये जो हमारी कहानी है, कौन दबा रहा है, कौन दबा रहा है, एक तो मिल गया मुझे, कौन दबा रहा है, कौन दबा रहा है, ये आपका प्रेशर डिफरेंस दबा रहा है. तो द फर्स्ट थिंग आई फाउंड आउट हु इज कंप्रेसिंग द esophagus फ्रॉम डाउन, दैट इज योर, द रीजन इज इंट्रा-abdominal लेंथ ऑफ esophagus, क्योंकि सम पार्ट ऑफ द esophagus इज इनसाइड द abdomen, दैट इज गेटिंग कंप्रेस्ड अंडर द प्रेशर डिफरेंस. फिर दूसरी बारी है कि यहाँ पे यू सी देयर आर दिस मस्कुलर, ये फंडस ऑफ द स्टमक है, and there are muscle fibers which are going to arching across it. Now this is what we call it as the sling muscle fibers of the fundus of the stomach. Now this sling muscle fiber of the fundus of the stomach is anchored in this particular fashion. Now because they're anchored at one particular root, they're anchoring at one particular root, every time the stomach contracts, these muscular fibers contract. When the fiber contract, this lumen gets compressed. तो दूसरा बंदा मिल गया कि कौन दबा रहा है. It is the sling muscle fibers. It is the sling muscle fibers of the fundus of the stomach. Of the fundus of the stomach. Sling muscle fibers of the fundus of the stomach. It is the sling muscle fibers of the fundus of the stomach is your second guy, right? Now the third one, you can see there's a very sharp angulation which is here. That is the gastroesophageal angle. It is such an acute angle that the stomach compresses the esophagus. इसके पीछे से आके ऐसे दबाता है. Now, as it is compressing the lumen, again, मेरा objective क्या है? ऐसा कौन है जो उसको दबा रहा है? ये fundus जो ऊपर angle की वजह से ना, it is coming across and pressing the esophagus. It is the sharp angulation at the gastroesophageal junction. So we say that is gastroesophageal junction angle, which is an acute angle, which is called as the angle of His. Right? That is also contributing to it. Fourth, obviously, the crus of the diaphragm, or I can say the crura of the diaphragmatic muscle fibers. We say crura of the diaphragm. The crura of the diaphragm and it has been found that there is increased tone at the lower esophageal sphincter. So there is somehow the tone of the muscle is slightly higher. So the muscular tone at this area is slightly higher than the rest of the esophagus. So that also contributes. When you go inside the lumen, if I just go in, I'd remove the crura here. And if I go into the esophageal lumen, you will notice within the esophageal lumen, you have this at the G junction, these are these hypertrophied mucosal folds. Now these hypertrophied mucosal folds are going to help. These hypertrophied mucosal folds are going to help because when they contract, these hypertrophied mucosal folds will cause interlocking mechanism. And when they cause interlocking mechanism, they will result in watertight seal. They result in watertight seal. So the last one to be remembered is going to be hypertrophied. They are hypertrophied mucosal folds. They are hypertrophied mucosal folds at the gastroesophageal junction. At the gastroesophageal junction. So what are the structures? So हमारा पूरा concept ये था. We wanted to know who is compressing the esophagus from outside. Now, 1, intra-abdominal length of the esophagus. 2, it is sling muscle fibers of the fundus of the stomach. 3, sharp angulation at the G junction. 4, the crura of the diaphragm. 5, increased tone at the lower esophageal sphincter or the junction per se. And 6, hypertrophied mucosal folds at the GE junction. And that is what it resulted in to make it behave like sphincter, right? So you have two basic concepts which are here. One, you have anatomical sphincter. Another one is a physiological sphincter. Anatomical sphincter, these muscles, when they contract, they make it behave like sphincter. I know these muscles are causing the sphincter mechanism, so I know it is anatomical. Physiological, there is nothing which looks like sphincter, but all these components, which I say, all these components make it behave like sphincter. Hence, it is called as lower esophageal sphincter. Carry a message. Upper esophageal sphincter is anatomical sphincter. Lower esophageal sphincter is going to be your physiological sphincter. This is all that we should know in the surgical anatomy of the esophagus. As we move down, we'll keep on adding a little bit tiny. For example, nodal basins. We'll talk about segmental vascularity, which is going to drive from aorta. All that when we talk about surgeries per se. But this is the root basis of the esophagus and the GIT. We have started today. We've tried to explain every single component in a bit by bit. I will upload the notes. Go take a look at it. Read it, understand it, come back tomorrow at 9 o'clock and we'll start with congenital disorder of the esophagus. Until then, thank you, goodbye, good night, and thank you for rejoining. And your support means amazing. I've been seeing there are a lot of people who've been watching online. We started to build this community, I think 3 months ago, and we're quite doing decent. Thank you for all the love and support. I'll continue to do so. A little bit of encouragement from your side means the world to me. Keep encouraging, and whatever questions you have, any queries, keep posting. Thank you so much. Good night. Take care. Bye-bye.